Okay, so we will be treating an area that you see on the monitor right now that is a lower implant with a very thin tissue. In the clinical view, you can see the tissue barely covers the implant. There's no bone underneath that tissue, and there's some deposits on the surfaces that we'll remove. And we'll graft from the patient's left canine through the right lateral incisor, so that we're treating primarily the implant and the right central incisor, but I'll include the right lateral just to make the graft stronger. And also we'll include the canine because the tissue is very thin over the canine. Coming for a clinical view, we can see the site after I've done the cleaning. So I've replaned, flossed, removed all the deposits from the implant surface as well as the teeth, and then used EDTA to remove any remaining small amounts of deposit that might be there. So what you can see now is very thin tissue facial to the implant, frenum attachment that's rather high, somewhat of a shallow vestibule, certainly at the implant site, significant recession on the right central incisor, and a papilla level that means we're not going to cover any of that implant, and maybe half of the root of the central incisor. So mostly this will be for augmentation to try to maintain this implant. The implant might be angled a little bit, but if you look at the position of the crown, it looks like the tooth's in lingual version. I don't think the implant is. I don't think it's in a bad position, but it's maybe a little bit prominent. A little bit of recession on the patient's left lateral incisor, none on the canine, but the tissue is very thin. So to access this area with a tunnel prep is rather difficult. So we will use an access incision through the papilla between the canine and the lateral on each side, and that should give me better access to do the development of the tunnel across the midline and access to augment the patient's left canine. So we'll make an incision between the canine and lateral incisor in the papilla. And we'll do that on each side. Turn toward me a little bit. And this is just a layer of papilla, so it has a very thin facial to lingual thickness. And the rest will be tunnels. So I'll use the end cutting intrasulcular knife to simply press through the base of the sulcus to crest of bone around each tooth. Some of this may block. So I can show you in this angle. I came through the sulcus facially around the canine and joined that incision with the papillary incision. I'll do the same thing now around the lateral incisor as we approach the implant. And this incision is through the base of the sulcus to crest of bone, facially and then approximately on each tooth. Now at the implant site. And we expect the papilla to be potentially weak from facial to lingual in all sites, but particularly around the implant. And we'd like to protect the papillae so that they don't separate, but due to the potential weakness of the papilla, that's a risk. Papilla separation is a risk. Just blot. Don't wipe. So this papilla has been raised. So I'll just connect that papillary incision with the intracellular incision. I'm just going to retrace this intracellular incision at the central incisor. Very delicate tissue there. So we completed the initial incision, and next I'll do the elevation. So we use the micro elevator and do a full thickness elevation. And this is extended well past the mucodental junction. And I have the elevator with the curve facing downward because there's an undercut here at the canine that I need to negotiate, and it's a little easier with the curve facing downward. And working past that undercut, mesial to the canine. So the undercut is right in this area here, and I believe I'm relatively well past it. A little moisture, please. Wet gauze. So I can work from this little flap opening, and I can work laterally toward the lateral incisor. So I'm working in this direction. I'm encountering a little bit of resistance, and let's see if I can work through the sulcus here. To free up some of the attached tissue. And I'm hitting a little ledge that's just beneath the surface here. That's giving me a little bit of resistance, kind of like an undercut at the canine. So I'm working pretty much to the midline. So if you see, I can go through this open papilla, and I'm that far over. And I'm again using the curve facing downward, which I can do because it's an open papilla. So I don't stretch the margin, that's the point. When you're doing a tunnel technique, the problem is to get this the dissection started through the sulcus. You often stretch the margin and you run the risk of tearing it. So you typically will go in with the curve facing outward, and you can slide under the margin without stretching it. But here, since I've opened the papilla, I can work with the curve facing downward. I've pretty well worked around about half of the canine. So I'm working distally now. And I think you can see how thin that tissue is. Because you can see the instrument through it. And I'm going to continue this intrasulcular incision on the canine. It's a kind of a semi-intrasulcular incision because of the mesial papillar incision. But I've got that pretty well dissected. I may block this. I'm trying to get this to an angle where I won't, but that blocking. So I'm getting under that papilla facially. We don't really need to advance this. Just augmentation on that canine. So that dissection is pretty well done. Part of what I'm doing here is working toward the implant because the tissue is so weak over the implant. It's also weak over the other central incisor. So if I dissect toward that, I take the tension off of that tissue and have a better chance of elevating it without tearing the margin or stressing the tissue. The front. And the same as I did on the other side, I'm working this direction. Working toward the implant. I'm going to switch with the curve facing downward now. I'm pretty near the midline. I want to switch with the curve facing up. Getting under the papilla between the lateral and the implant. And you can expect all kinds of irregularities underneath the surface here. I think you're seeing a little papillary movement as well. So I've gotten close to the midline from that side. I'm going to switch and see if I can reach it from the patient's right side. We've done pretty well. We have the really delicate part still to do. That's the margin. And that seemed pretty good. I'm getting some movement of that tissue now. I've done all the easy part. So I'm going to go in with a curve facing downward again. I think you can see the papilla moving at the in between the incisors. So I'm doing as much as I can from the apical toward the coronal to move that tissue. Could you see that moving? Okay, and I'm going to try to do the same thing from this other side now. Like I say, I'm hitting a lot of irregularities. I feel the bone margin. Let's see if I can mobilize this papilla facially. We're going to come in from this open papilla. We'll change with the curve facing downward. I don't know if you can hear that noise, but I'm hitting some little ledges. See if I can slip into this sulcus. A little attachment there still. Blot that for me, just blot. And a little difficulty there. I'm going to work from the lateral toward that implant. And that was with the curve facing outward. I'll try the straight end. See if I can do a little bit better there. Check this papilla this way. We still have some attachment in there. But you see how that moves up now? Makes you see the papilla moving up at the implant site. So I think we're pretty good with the blunt dissection. And we'll finish with sharp dissection in a moment, but I'm going to measure for the graft and trim the graft next. And we have an alloderm graft that has been soaking in normal saline, 2 separate washes, 10 minutes per wash. You see the thickness, pretty even thickness of tissue. Nice graft. This is the connective tissue side, and I'll fold it over, and you can see the basement membrane side. So I'll place it on here. Actually, I'm going to inspect both sides. Place it on this gauze on a cutting card. And this cutting card has markings, so it is 5, 10, 15, 20, 25, 30, 35, 36 is to right here. So I can mark that on the graft with the probe. And then cut it at 36. And then I want it about 7 millimeters in vertical dimensions, so we lay the probe on there, and at 7 millimeters I will draw the 15 blade through that graft. And now then we have a 7 millimeter by 36 millimeter graft. And you'll see we have enough tissue here. This is a pretty nice one. We probably could do 3 grafts out of that one. It's exceptionally wide. It's about 21 millimeter wide graft, and the length of it we'll look at in a moment. Put the graft in the PRP, platelet-rich plasma, and soak there for at least 2 minutes while we finish the dissection process. The rest of our process will be with a new instrument called the Arrowhead, and it's just a short orband, basically short modified orband, short blade, reduced blade length, longer shank, so I can slip under the margin with less risk of injury with the side of the blade, injury to the margin. And we'll turn a little bit. So I'm simply, I don't know if I block your view here. I'm extending the dissection apically. Now I'm entering the tunnel part. You see it's much easier, of course, through the open papilla. In the past I did an occasional open papilla, actually every other tooth open papilla, and tunneled the intervening ones. And that makes the dissection process easier because you have better access. So we're using the same principle here, just having limited access, occasional papillary incision. It's most useful when you're doing augmentation, grafting the lower anterior, where you don't have the access for dissection through the sulcus that you would have if you had significant recession. So this offsets the access you have, or the substitutes for the access you have when you have deeper recession. So now we'll go through the sulcus. Have the, no. Going through the sulcus of the central incisor. And this is really a great place for this arrowhead because it's a really small sulcus I'm working through. And we'll use the regular orband knife next, or regular modified. And I'm just checking to be sure it's patent. It appears that it is. Gonna hit a little bit of an obstacle here. And we should be good. So now we're ready to insert the graft. And we're not elevating papillae because we're really doing very little coronal advancement. So I have elevated the papillae with the elevator from the facial aspect, but I'm not doing a full elevation from the interdental site because the papillae are very delicate. So we're isolating the site as we would normally, placing the graft to minimize salivary contamination. And we'll put the graft in through the papillary opening. Photo. Insert the graft through the papillary opening. And with luck, we'll see it show up on this other side. I was able to grasp it. By going through the papilla here. And we'll see it at that location. And that is the end of the graft at the lateral incisor. Now we'll go under the papilla distal to the canine. The graft is positioned facial to canine through lateral incisor. So now we'll suture using continuous sling suture method. And we'll start at the distal of the canine, engage the overlying tissue and the graft about 4 millimeters off the margin at the root line angle. Pass the needle through the embrasure. And back to the facial. So it starts out as a sling around the canine. Now we have an open papilla. We're doing okay, Scott?
That's good.
So we don't have to go under that papilla. So I'll simply go to the next spot, which is the lateral incisor, and Shannon will hold the graft in place. So I penetrate perpendicular to the surface through the overlying tissue and the graft, and draw that suture down so it's over that papilla. And we'll go through the embrasure. Distal to the lateral, and then go back to the facial, coursing around the lingual of the lateral. Now I have to go under the papilla, a little delicate spot here. Thank you, perfect. See the roll of the needle holder, Brian? My roll technique.
Yeah, the roll.
The roll is the Allen roll technique.
Roll.
Now then I'll suture distal to the implant, exit through the sulcus, penetrating through the overlying tissue and the graft. Go through the embrasure. Shannon captured the needle and passed it back to the facial. And then we'll go under the papilla at the midline. Another very delicate papilla. And we'll engage, since we're crossing the midline, the mesial of the central incisor. So now we pass under the papilla between the central and the lateral. Thank you, Shannon.
You can leave that in.
It's good to have your assistant guide you. And now we're to the last tooth. Penetrate through the overlying tissue and the graft at the mesial of the right lateral. And it's just augmentation there. It's not even necessary for augmentation. It's just to extend the graft to make it stronger over the incisors, actually. This lateral extension. And pass around the lateral back to the facial. And I'll engage pretty much under the middle of the papilla here, engaging the overlying tissue and the graft. Again, we're not trying to coronally advance this, so the positioning at the root light angles is not necessary. But if I place a suture right over that papilla, I don't need an extra suture to adapt that papilla. So now I'll go through the embrasure. And we'll go back to our starting point. So we go around the lateral. And under the papilla. Snug that up gently. And by the way, I'm using a 6/0 polypropylene suture on a C17 needle. Shannon's holding that graft in place. I go through the overlying tissue and the graft. Through the embrasure, around the central, back to the facial. And under the papilla to reach the implant. Snug that up gently. And you notice we're grafting under a papilla. So with a dense graft, that should displace that frenum that's at the midline papilla. And I want to place this suture so it's at least 3 millimeters away from the initial penetration at the implant site. If you're approaching 2 millimeters, I think you can strangulate the tissue that's already been compromised from having elevated it, and you could have a sloughing of that tissue in that location over the graft and expose the graft. So we've come around the implant now. We go under the papilla. Snug that up gently. And engage at the distal of the lateral through the overlying tissue and the graft, approximately 4 millimeters off the margin. And that's, again, very shallow recession on that tooth. We're advancing it a little bit coronally, but not much. And now we're to the incised papilla, mesial to the canine. No recession on the canine. So I can place this suture under the middle of the papilla. Shannon's holding that graft in place because we don't want the graft overlying the papillary bed. Because the papilla needs to reside there, the incised papilla. And now we'll tie, and it will be finished. So the tie, I'd like to do 3 throws clockwise. Because that will hold. So tie it gently. And then 1 counterclockwise. And 1 more clockwise. And we trim that suture, the ends about 6 millimeters. So that it won't stick the patient. It'll be relaxed and won't bother the patient. So now we see the completed surgery. And once again, our intent here was primarily augmentation because of loss of papillary fill between the implant and the central incisor on the right. Root coverage to a degree on, of course, the minimal root exposure on the left lateral incisor. Augmentation of the left canine. So suturing is finished. There's 1 knot. This was a continuous sling suture. It looks like that papilla is not well supported. So let me see if I can move that suture a little bit. So now you see the finished surgery with the augmentation primarily of the implant as well as the right central incisor, augmentation of the left canine, a little bit of root coverage on the left lateral incisor, but our primary goal was augmentation of the implant and the right central incisor where there was essentially no attached gingiva. And of course you saw the implant showing through the tissue. So we'll see how this works. So our last step is to apply PRP. So the graft had been soaked in PRP, and then we add PRP at the margins. Just that soak under the margin. And you don't need a lot. Primary PRP application was from soaking the graft. So we're finished, and now it's just a matter of healing.